This is where we take the most complex scientific blueprints, stack up your source materials, and, well, we hand you the intellectual shortcut to mastering what truly matters. We're here to make you well-informed and to do it quickly and thoroughly.
Today, we are tracing a really extraordinary and often unseen event that happens trillions of times a day across the globe. We're talking about the precise, regulated journey of a drug inside the human body.
It seems so simple, doesn't it? You take a pill, you get better. But the foundational science behind that simple act it's just vast.
It really is.
We're moving beyond just knowing what a drug is supposed to do.
Yeah.
We're doing a massive download of the foundational science, the chemistry, the diverse origins, and the absolutely critical routes of administration.
Our mission today is laser-focused on the general pharmacological principles. We're establishing the vocabulary, the mechanics, the things that dictate whether a drug succeeds or fails in its mission. And we're pulling all these essential nuggets from the very detailed source materials you provided.
Okay, let's start with the big picture then. Defining the field itself. This is the science of drugs pharmacology.
Right. And the term itself is ancient. It's rooted in Greek.
Pharmakon, I believe.
Yeah.
Which means drug, or, and I find this fascinating, it can also mean poison.
It can. And that's paired with logos, which means, discourse in or the science of. That duality you mentioned, drug and poison, is absolutely central to the entire discipline.
So this science is built on two. Let's call them gigantic, non-negotiable pillars.
Yeah, that's a great way to put it. To be effective in medicine, you really must understand both sides of the relationship between the chemical you're introducing and the biological system it's entering.
Okay, so pillar one, this is the active side, right, the effect. It's called pharmacodynamics.
Uh-huh. The Greek root there is dynamis, which means power.
So the question here is really clear and direct. What does the drug do to the body?
Pharmacodynamics is all about that molecular interaction.
Yeah.
It's how the drug exerts its power, how it finds its specific target, whether that's a receptor, an enzyme, or, an ion channel. It's the mechanism of action. It's the chemical dialogue the drug has with your physiology.
To produce an effect.
To produce that therapeutic outcome, yes.
And pillar two must be the flip side of that coin. The environment, the body's response system, pharmacokinetics.
Right. And the Greek root here is kinesis, meaning movement.
So this asks the equally important, and I think often overlooked, question, what does the body do to the drug? It's sort of the silent partner in all of this.
It really is. Pharmacokinetics tracks the entire itinerary of the drug within your system, which directly governs the correct dose, how often you need to take it, and, how long it's going to work.
And this involves movement and alteration, which you break down into 5 major stages.
Yes, 5 major stages. We use the acronym ADBBE, so that's absorption, distribution, binding or localization, iotransformation, that's metabolism, and finally, excretion. We'll definitely come back and dive into all 5 of those because they are crucial for understanding the routes of administration.
So if pharmacodynamics is the drug's job description, what it promises to do, then pharmacokinetics is its travel itinerary and its survival guide, determining if it even makes it to the office on time.
That's a perfect analogy, and the two are absolutely inseparable when you're calculating efficacy and safety. You need both.
Okay, let's transition from the mechanics to the language we use. Before we trace that journey, we really have to pin down the protagonist here. What exactly qualifies as a drug in the modern scientific sense?
Historically, the term is quite descriptive. It comes from the old French word drogue, which just means a dry herb.
Simple enough.
Very. And the classic definition was pretty narrow. A single active chemical entity that's used for diagnosis, prevention, treatment, or cure of a disease.
But the goals of modern healthcare are broader than just curing disease, aren't they? I mean, we often use substances just to explore a physiological system or modify it for, say, health maintenance.
Exactly. And that's why that classic definition felt a bit limiting. This leads us to the much more robust World Health Organization definition.
WHO definition, okay.
To the WHO, a drug is any substance used or intended to modify or explore physiological systems or pathological states for the benefit of the recipient. That word modify is key.
Right. It allows for preventative agents, diagnostic agents, and substances that adjust health, even if there's no defined disease being cured yet.
Precisely. It's a much more flexible and accurate definition for modern medicine.
And a quick point on terminology.
Yeah.
Our sources emphasize that while we might colloquially use drug for, illicit or addictive substances, in therapeutic science, we generally try to use medicine for the health-promoting application.
Right. And drug for the active chemical agent itself. It's a useful distinction.
So pharmacology doesn't exist in a vacuum. It's the bedrock for several other disciplines. The first one you mentioned is pharmacotherapeutics.
Yes.
This sounds like the application phase. It's taking all that data on dynamics and kinetics and applying it practically, right? This is where the paper science meets the patient's illness.
That's exactly what it is. Pharmacotherapeutics is the fusion of pharmacological information with the knowledge of the disease itself. It involves three key things: selecting the right drug, determining the exact dose, and setting the duration of treatment.
And all of that is customized to the patient's specific condition and biology.
All of it. It's the art of practical, personalized dosing.
Then there's clinical pharmacology. This feels like the field that provides the evidence base for everything we're talking about.
It is. Clinical pharmacology is the scientific study of drugs, both new ones and old ones, but strictly in humans. This means doing those pharmacodynamic and pharmacokinetic investigations, not in a petri dish, but in healthy volunteers and actual patients.
So it's essential for bridging the theory with real-world human variability.
You can't do without it.
Now let's turn to chemotherapy. As you noted earlier, many people, myself included, instantly associate this with cancer treatment. But the source provides a definition that emphasizes a really crucial functional difference from other drugs.
It does. Chemotherapy is defined as the treatment of a systemic infection or a malignancy using specific drugs that have selective toxicity.
Selective toxicity, that's the key phrase.
That is the vital insight. The drug must be highly toxic to the thing you're trying to kill, the invading organism, the malignant cell, while causing minimal, ideally zero damage to the host's own cells.
So that focus on the target, the invader, is what separates a general drug from a chemo agent.
And that leads directly to this core definitional split: pharmacodynamic agents versus chemotherapeutic agents.
Right.
A pharmacodynamic agent is designed to act on you, the recipient.
Okay.
A blood pressure drug, for example, it modifies your system. A chemotherapeutic agent is designed to inhibit or kill an invader, a bacterium, a parasite, a cancer cell. Its primary goal is targeted destruction, not host modification.
Although side effects often happen when that selectivity isn't perfect.
Oh, absolutely. That's where the challenge lies.
It's the difference between remodeling your house, which would be pharmacodynamic, and, well, exterminating pests, which is chemotherapeutic.
Perfect analogy. And we also have to define pharmacy. While we're talking about the science of drug action, pharmacy is the art and science focused on the preparation side.
So compounding, dispensing, purification, quality control, all that.
Exactly. And when that scales up from a local pharmacy to a huge chemical plant, that large-scale manufacturing moves into a field called pharmaceutics, which is really a technological science.
Finally, we revisit the other half of that Greek duality you mentioned, toxicology.
Right, the study of poisonous effects, not just from drugs, but from household chemicals, industrial pollutants, everything.
And the essential takeaway here, which really reinforces the idea of pharmacon, is that the very same substance can be a drug or a poison.
Depending entirely on the dose. It's the concentration that determines the outcome. A little bit might save you, a lot might kill you.
That really sets the technical groundwork so we understand the language. Now let's get into the exciting origin story. Where do we find, or how do we create, these active chemical entities?
The origins are just remarkably diverse. They span deep history and cutting-edge science. We have to start with the oldest and longest-serving source: plants.
Plants are nature's chemical factories. I mean, they contain a multitude of biologically active substances and have formed the basis of traditional medicine for millennia. You think of Chinese medicine, Ayurvedic, Aztec traditions.
Absolutely. We rely on history for things like opium, belladonna, ephedra, cinchona, which gives us quinine and digitalis, from the foxglove plant.
And these active compounds generally fall into distinct chemical categories. The first are alkaloids.
Right. These are alkaline nitrogenous bases, and they're known for their extreme potency. They're often active even at very, very low doses.
The list of significant alkaloids is like a who's who of powerful drugs. Morphine, atropine, nicotine, cocaine, and even some vital chemotherapy agents like vincristine.
They are. And they're usually prepared as water-soluble salts like a hydrochloride or sulfate, just to make sure they can be dissolved and administered effectively.
Next up, you have glycosides.
These are chemically more complex. You have a non-sugar part, which we call the aglycone, and that's linked to a sugar moiety. And that sugar part is often really crucial for solubility and transport within the body.
The most famous examples here would be the cardiac glycosides, digoxin, for instance, which are essential for certain types of heart failure.
Correct. And you also find them in purgatives, like senna. The sources also note an interesting parallel with aminoglycoside antibiotics. Even though they come from microbes, they share that same sugar moiety structure.
We also get oils from plants.
We do. And we distinguish them by volatility. So fixed oils are non-volatile, like castor oil or olive oil. We use those for food or topically. Then you have the volatile or aromatic oils, think eucalyptus, peppermint. They're fragrant, and we use them as flavorings or stimulants.
So moving beyond plants, we look to the rest of the natural world. Animals have provided sources since antiquity.
For sure. Things like adrenaline, thyroxine, and historically insulin before we could synthesize it. We also still rely on animals for anti-serums and many vaccines.
And, of course, the microscopic world,
Yeah.
the microbes.
This is where the vast majority of our infection fighters come from, our antibiotics. Penicillin came from a fungus, while broad-spectrum agents like tetracycline and gentamicin come from actinomycetes.
And finally, a smaller category, minerals.
Right. Though it's less common now, we still use essentials like iron salts, lithium carbonate for bipolar disorder, and antacids based on magnesium and aluminum, and iodine, of course.
So natural sources are the foundation, but the modern drug explosion really began in the 19th century with the rise of synthetic chemistry.
This freed us. It freed us from the limitations of just hunting and harvesting these compounds from nature.
And it offers massive advantages. You get guaranteed purity, you can manufacture as much as you need, and it's usually significantly cheaper than relying on, variable natural yields.
But the greatest advantage, I would argue, is the pursuit of selectivity. Chemists aren't just duplicating nature anymore. They are designing molecules to perform specific, targeted functions that natural compounds often lack.
You're talking about entirely new drug classes.
Entirely new classes. Think of ACE inhibitors for blood pressure, benzodiazepines for anxiety, or the HIV reverse transcriptase inhibitors. This is molecular design tailored for a specific biological lock.
And here's a fascinating technical detail that underscores that precision. Chirality. Our source notes that many synthesized drugs are chiral.
Which means they exist as non-superimposable mirror images. The classic analogy is your left and right hands. They're mirror images, but you can't lay one perfectly on top of the other.
Why is this so critical in drug design?
It's critical because often only one of those mirror images, we call it the active enantiomer, actually does the therapeutic job. The other one, the inactive mirror image, is at best just useless baggage. At worst, it can cause entirely unwanted side effects.
Wow. So it reduces the potency and can even increase the toxicity of the final drug.
It can. So if you can produce the drug as a single active enantiomer product, you get a much superior therapeutic agent. You've gotten rid of the unnecessary and potentially harmful other hand.
It's like sending the key that fits the lock perfectly, instead of a whole key ring with the right key and a dozen others that might jam the mechanism.
Exactly. And if synthetic chemistry is about precision, then biotechnology is about custom engineering. This is the new frontier, accelerated by recombinant DNA technology.
This is what allows us to produce complex peptides and proteins that are identical to, or even custom-designed versions of, molecules that are naturally found in the human body.
We rely on this for massive biological products today. Human growth hormone, human insulin, monoclonal antibodies, erythropoietin. It allows us to design and scale up these proteins with incredible fidelity. It's truly revolutionary.
It's the complete cycle, then. From finding potent chemicals in plants to synthesizing targeted small molecules to genetically engineering these perfect large biological proteins.
So once we've established the origin and purity of the active drug, whether it's a synthetic ACE inhibitor or a genetically engineered insulin, the next big challenge is protection and delivery.
And this brings us to the crucial discussion of dosage forms.
The dosage form isn't just a container, it's a sophisticated delivery system. It's the finished product. It combines the active ingredient with what we call excipients.
The binders, the fillers, preservatives, all the other stuff.
All the other stuff. And it's formulated into a specific format, like a tablet or a liquid. And its function is multifaceted. It protects the drug, it determines the route, and critically, it controls the rate at which the drug is absorbed by the body.
Before we delve into the forms themselves, let's quickly classify them legally. We have prescription drugs, which need a specific order from a doctor.
Right. And then you have non-prescription or over-the-counter OTC drugs. These are things generally deemed safe for self-administration for minor ailments. Think aspirin, paracetamol, antacids,
The accessible
the
medicine.
accessible ones. And then there's a fascinating and vital third category, orphan drugs.
Okay, what are those?
These are biological products for the diagnosis, prevention, or treatment of a rare disease. The U.S. definition says this is a condition that affects fewer than 200,000 people.
The challenge there, of course, must be commercial viability. If the patient population is that tiny, the massive investment needed for drug development would be really hard to recoup.
That's the core problem. So, to incentivize their creation, governments and institutions provide support. They offer things like tax benefits, grants, and sometimes even exclusive market periods to protect the pharmaceutical company's investment, even for that small population.
So these incentives are specifically designed to make sure rare diseases don't get ignored just because of market forces.
Precisely.
All right, let's move to the tangible forms, starting with the most common, the solid dosage forms.
The simplest are powders, just finely pulverized dry drug. You can use it topically, or for oral consumption, like with oral rehydration salts.
But the undisputed king of dosage forms has to be the tablet.
Without a doubt, it's powdered drug, compressed with binders and fillers. But the real revolution here is in the coating and design, which tailors exactly when and where that tablet breaks down in your body.
So you have the simple variations like chewable tablets or dispersible ones that you drop in water.
Right. And then you have the really strategic forms, the sublingual tablet, for instance.
That's the one that goes under your tongue. It's strategic because it dissolves there for rapid absorption directly into your bloodstream, completely avoiding that first path through the liver we talked about.
Crucially, yes. Then we have specialized coatings. The enteric-coated tablet has a polymer shell that resists the highly acidic environment of the stomach.
So it passes through the stomach intact.
It does. It's designed to only dissolve when it reaches the less acidic environment of the duodenum. This protects drugs that are sensitive to acid, and it also protects the stomach lining from drugs that might be irritating, like high-dose aspirin.
Then you have sustained or extended release tablets.
These are even more complex. They often contain granules or layers that dissolve at different rates. The goal here isn't to protect the drug, but to release it slowly over 12 hours or even more.
Which means a patient can take a pill once a day instead of 3 or 4 times. That's a huge win for just getting people to take their medicine correctly.
A massive win for patient compliance. Our sources also mention the archaic pills, which were sticky, spherical masses, and, of course, capsules, the gelatin shells, which can also be designed for rapid release or extended release.
And finally, there are other specialized solid forms. Lozenges for local action in the mouth, suppositories for rectal insertion.
Which can be for systemic effect if the patient can't swallow, and also pessaries for vaginal insertion, and bougies, which are urethral cones.
Let's switch gears to the liquid and semi-solid dosage forms.
Aqueous solutions are the simplest, just the drug dissolved in water. Suspensions are a bit more complex. It's an insoluble drug dispersed in water, and it needs an emulsifying agent to keep the particles stabilized.
And the key here is if you see suspension on the bottle, you must shake it before you use it.
You absolutely must. Otherwise, you're getting an unpredictable dose.
We often confuse the sweetened liquids. What's the difference between an elixir and a syrup?
So elixirs are hydroalcoholic solutions. They contain alcohol. Syrups are highly concentrated sugar solutions, and syrups are notably thicker, and that viscosity is why they're so often used for cough relief. That physical coating action helps soothe the throat.
Okay, for external application, there's a critical difference between ointments, pastes, and gels. Why choose one over the other?
It's all about function. Ointments are greasy, semi-solid, and their defining feature is that they are occlusive. They form a protective barrier that seals moisture in, so they're best for dry, chronic lesions that need hydration.
What about pastes?
Pastes have a very thick consistency because they have a high powder content, like zinc oxide paste. You apply those to inflamed, oozing skin because the powder absorbs moisture and dries the surface.
And gels are the non-greasy option.
Right. They're non-greasy, viscous solutions, often preferred for hairy areas or just for patients who dislike the feel of an ointment. They provide a non-occlusive cooling effect.
And lastly, for this category, injections. Sterile solutions or suspensions, sealed in ampoules or vials.
And sometimes supplied as a dry powder that needs to be reconstituted with sterile water before use.
Finally, a route that is really technologically demanding, inhalations.
This is where drugs are administered as gases, volatile liquids, or as fine particle solids carried in the air using devices like nebulizers.
And this relies entirely on physics, doesn't it?
Hmm.
For the drug to reach its target in the lungs, the bronchioles and alveoli, the particle size is absolutely critical.
It is. The sources state the particle size must be precisely between 1 and 5 micrometers. To put that in perspective, the finest dust motes you see floating in a sunbeam are often bigger than that.
So if the particles are too large, say over 10 micrometers,
They just deposit immediately in the back of your throat. They get swallowed or exhaled, and they never reach the deep lung tissue where the absorption is supposed to happen. It's a perfect example of pharmacokinetics dictating dosage form design.
that attention to detail, the physics of delivery is just astonishing. So, with the sources and forms established, we can finally trace the drug's itinerary, the systemic journey, routes of drug administration.
The choice of route is the ultimate act of personalized tactical medicine. It's dictated by a really crucial checklist of factors.
You have to consider the drug's properties, right?
Huh.
Is it stable in acid? Is it fat soluble? And you have to consider the site of action. Do you want it local or general?
And most importantly, you need to know the speed required and the condition of the patient. Are they unconscious? Are they vomiting?
But the single most challenging factor for most drugs, the central pillar of this whole section, is avoiding destruction by digestive juices, and even more aggressively, what we've been calling the first pass metabolism.
That's the main villain of the story for oral drugs.
Let's quickly cover the minor routes first. The local routes, where we want maximum concentration right at the target and minimal systemic absorption.
Topical is the most common creams, ointments applied to the skin or mucous membranes for a local effect. For deeper tissues, we can use guided injections, like an intra-articular injection right into a knee joint, trying to keep the drug contained there.
And then there are specialized routes, like direct arterial supply, where you can infuse chemotherapy right into a localized tumor to maximize its concentration there and minimize systemic toxicity.
Right. Now for the main event, systemic routes, where the goal is for the drug to successfully enter the bloodstream and distribute throughout the body.
But before we detail those routes, let's circle back and complete our understanding of those 5 kinetic phases you mentioned. ADBSE.
Great idea. We've really only touched on A for absorption and the start of B for biotransformation, so let's unpack the full process.
Okay, so A is absorption.
Simply the drug entering the bloodstream from wherever you administered it. How and how fast that happens depends entirely on the route.
Next is D for distribution.
This is the drug moving from the blood out into the body's tissues. And this is crucial because it dictates where the drug goes and how much is available to actually reach the target site.
And what governs that distribution?
2 main things: lipid solubility and protein binding. If a drug is highly lipid soluble, it can cross cell membranes easily, including the blood-brain barrier. But if a drug is highly protein bound,
Meaning it clings tightly to proteins in the blood like albumin.
exactly, then it's temporarily trapped in the bloodstream and it can't easily enter the tissues to do its job. Only the unbound fraction of the drug is active.
So if a drug is, say, 95% protein bound, only 5% of that dose is actually able to work at any given time.
Yeah.
That has massive implications for dosing.
It has huge implications. Next up, we have B binding localization storage. Some drugs just preferentially accumulate in specific tissues. Lipid-soluble drugs, for example, tend to build up in fat tissue. Bone can also act as a storage site.
And what's the implication of that storage?
It creates a reservoir. The drug is temporarily inactive while it's stored, but it's released slowly back into the bloodstream over time. This can delay the elimination of the drug, which can sometimes lead to prolonged low-level effects or even toxicity if you give the next dose too quickly.
I see. Then comes the major phase.
Yeah.
The second B, biotransformation. This is metabolism.
This is the body's attempt to chemically alter the drug, usually into forms that are more water-soluble, so they're easier to get rid of.
Our source mentioned the liver is like a demolition crew,
Hmm.
but it's more complex than just simple destruction, isn't it?
Oh, absolutely. Biotransformation generally happens in 2 stages, mostly in the liver. Phase A reactions are called functionalization reactions. They involve oxidation or hydrolysis, and they add or expose a functional group on the drug molecule. This makes it a bit more polar.
And what happens in phase 2?
Phase 2 reactions are conjugation reactions. The body takes that intermediate from phase I and links it to a big, highly water-soluble molecule that it has on hand, like glucuronic acid. This process makes the final molecule extremely water-soluble.
Ensuring it can't be reabsorbed by the kidney and is ready for excretion.
That's the goal. So the body isn't just destroying it, it's converting it from a fat-soluble molecule that wants to stick around into a water-soluble molecule that the kidney can easily flush out.
That is the perfect summary. And that brings us to E, excretion.
The final step. The elimination of the drug and its metabolites, primarily via the kidneys and urine, but also through bile, sweat, saliva, and even your breath.
Okay. Knowing those 5 stages is the prerequisite for understanding why we choose one route of administration over another.
Let's start with oral administration. It is the oldest, the most common, the most convenient, and cheapest route. It requires no specialized skills.
But the list of limitations is long, headlined by that colossal hurdle we keep mentioning, the first pass effect. Let's use an analogy to really explain the pathway.
Okay, so imagine the oral drug is a product shipment arriving via the main postal service. It gets absorbed from your gut and immediately enters the portal vein. And the portal vein is a superhighway leading straight to the central processing hub, the liver.
And the liver acts as the ultimate quality control and customs inspection facility.
Exactly. It's there, and also in the gut wall, that the drug is subjected to extensive metabolism, those biotransformation processes we just detailed. And this processing can significantly reduce the amount of active drug that survives that first pass and finally makes it to the systemic circulation.
So the bioavailability, the amount of drug that actually gets to work, can be really low and unpredictable.
Precisely. If 70% of the drug is destroyed during that first pass, the doctor has to give you a dose 3 times higher than what you actually need systemically, just hoping that the remaining 30% is consistent.
Which is why, if a drug is prone to that, or if you need rapid action, you have to find a bypass.
Hmm.
The most elegant solution is the sublingual or buccal route.
That's the tablet under the tongue or in the cheek. The oral mucosa is rich with blood vessels, allowing direct absorption into the systemic circulation. Crucially, the blood from your mouth drains directly into the systemic veins, entirely bypassing the portal vein and the liver.
Which means 100% of what's absorbed avoids first-pass metabolism. You get rapid action and predictable bioavailability. Perfect for something like glycerol trinitrate for immediate angina relief.
Another bypass option is rectal administration, often used when a patient is vomiting or unconscious.
The absorption there is often slow and irregular, but it provides at least a partial bypass, right?
A partial one. Drug absorbed from the lower rectum avoids the portal system, but from the upper rectum, it does drain into the portal vein. So you might get about a 50% bypass.
Good.
Better than 0, but not ideal.
Okay, then there's the prolonged, steady bypass, cutaneous or transdermal delivery.
This is applying the drug to the skin for slow, prolonged systemic absorption. It requires a highly lipid-soluble drug that can get across that outer skin layer.
This is where the transdermal therapeutic systems, the patches, really shine.
They do. They deliver the drug at a meticulously constant rate over days, completely bypassing the first pass effect and achieving really stable plasma concentrations. You avoid the peaks and troughs of taking pills.
We also mentioned inhalation as a systemic route for things like general anesthetics.
Yes, exploiting the massive alveolar surface area for both rapid absorption and rapid elimination. This allows for minute-to-minute control of the dose during surgery.
And the promise of nasal administration, used for some peptide drugs to bypass digestive juices, but the really significant advantage mentioned is its potential to bypass the blood-brain barrier.
Yes, offering a non-invasive way to get drugs into the central nervous system to treat neurological conditions. It's a very exciting area of research.
Finally, we have the high stakes, highest control routes, the parenteral routes. This means beyond the intestinal tract.
These require injection, and they bypass all the hurdles we've discussed. Their advantages are speed, reliability, and guaranteed avoidance of first-pass metabolism. They're essential for emergencies.
The trade-offs, of course, are cost, the need for sterility, and the risk of pain and injury. Let's detail the different injection methods.
Subcutaneous SC injection goes into the loose tissue just under the skin. Absorption is slower than an intramuscular injection, so it's not great for large volumes or for patients in shock, where blood flow to the skin is poor.
The sustained release techniques here are fascinating. You have the dermajet, which uses a high-velocity jet of air instead of a needle.
Right. And then you have the long-term, slow-release systems. Pellet implantation under the skin for weeks or months of release, and things like the siolistic implants, like Norplant contraceptives, offering drug delivery measured in years.
Next is intramuscular IM injection, which goes into large skeletal muscles. It's faster than subcutaneous.
Much faster, and because of the dense vascularity, it can handle both aqueous and oily suspensions. The one big risk is bleeding, a local hematoma. So the sources warn against using this route in patients on anticoagulant therapy. The risk of a serious deep muscle bleed is just too high.
And that brings us to the fastest, most critical route, intravenous administration.
Injected directly into a superficial vein, either as a rapid push, a bolus, or a slow infusion.
IV offers the non-negotiable gold standard, 100% bioavailability. The drug is immediately in the blood. That's why it's used in critical emergencies.
But that speed is also its greatest danger. The high, immediate concentration hits the heart and brain almost instantly, giving you very little time to intervene if there's an adverse reaction. It carries the highest risk of any route.
And finally, the highly localized intradermal ID injection.
This is what the drug is injected just into the skin, raising a small bleb. It's used primarily for local effects, like sensitivity testing or certain vaccines like the BCG.
That brings our comprehensive journey to a close. We established the two critical pillars: pharmacodynamics, the drug's power, and pharmacokinetics, the body's movement. And we now understand that involves 5 complex stages: absorption, distribution governed by that protein binding storage, biotransformation, and excretion.
We charted the evolution of drug sources from naturally occurring alkaloids through selective synthetic chemistry, all the way to the custom engineering of proteins via biotechnology.
And we followed the drug through the body, focusing on how the choice of dosage form and route oral, sublingual, transdermal, or parenteral is dictated almost entirely by the need to avoid that one massive checkpoint, the first-pass metabolism of the liver.
Understanding the meticulous planning required to ensure a drug's survival, its efficacy, and its safety inside the human body it's truly foundational knowledge for anyone interested in medicine and health.
So here's a final provocative thought for you to carry forward, building on some of the new kinetic details we explored. We noted how the nasal route can bypass the blood-brain barrier and how implants offer sustained, controlled delivery. Now, considering that highly protein-bound drugs are effectively trapped in the bloodstream and only slowly released, how might future drug delivery technologies, maybe involving molecular shields or targeted non-toxic carrier nanoparticles, be specifically engineered to temporarily disrupt or optimize that protein binding? Could that ensure predictable bioavailability for IV drugs, making the IV bolus less risky? Or could it even allow for long-term, low-risk, sustained-release injections that eliminate the need for hospital infusion lines entirely?
The future of pharmacology isn't just about finding new molecules. I think you're right. It's about refining the delivery system to perfectly match the molecule's kinetic requirements, turning today's high-risk interventions into predictable, convenient treatments.
Something profound to consider as you reflect on the immense complexity behind that single, simple pill. Thanks for joining us for the deep dive.
Until next time.